Listen, earlier we had a class regarding history taking. Regarding in that class, we actually went towards taking history of in case of abdominal diseases, actually of the abdominal system, of the gastrointestinal system. In this class, we are going to talk about history taking of respiratory system. We are going to talk about history of respiratory system. So in general, we know how to take a history, how to proceed, what to ask, what questions to ask when a patient is coming to us. So today we will be learning if a patient particularly comes to us with a respiratory cause, with any cough or anything like that, which seems to be like any respiratory disease. So what we will be asking the patient. So this is the initial scheme of the history taking. We will have initial inquiry. Initial inquiry you all know. We will be asking about his name or her name, patient's marital status, his family history, then socioeconomic history, where the patient is staying, and then drug history, what kind of drugs the patient is taking, is the patient taking any medications, is the patient having any past history, means if the patient is diabetic or hypertensive or anything, any other things. Then about his personal history. In personal history also, there is also history of addiction or any substance abuse. So we will also ask about these things. So these are the basic things we will be asking to the patient in general. Then the most common symptom in case of patient who is having respiratory disease is cough. So this is the most common symptom. So whenever any person is having any respiratory disease, then the person will be presenting as with cough. Likely, like some patient will be coming to you. He will tell that, okay, I am having this fever, then this runny nose, and this and that. And the patient will almost always tell you about cough, that I am having cough for 5 days, 3 days, 7 days, like that. So then about cough, what we will ask? We will ask the patient whether there is sputum production. Sputum, you know what is sputum? Can anyone raise your hand and tell me what is sputum? So sputum means productive cough. When there is some wet type of discharge coming out from the cough, that is called sputum. So cough can be dry cough also, that it can produce sputum also. Some people also present with dry cough. So firstly, we will ask whether the patient is having sputum production. Then we will ask about breathlessness, whether the patient is having breathing difficulty or not. Then we will ask about chest pain, because in some cases the patient may have chest pain while he is breathing, or the patient may also be presenting with cough or breathing difficulty, but the patient might be a cardiac patient. So in that case, we have to also evaluate about chest pain. We have to ask the patient if he is having chest pain or not, along with these other symptoms I have discussed already. Then hemoptysis, then any abnormal breath sounds. What is hemoptysis? Can anyone tell? Yeah, if someone is coughing out blood, he is having cough, and there is also coughing out of blood, then that is called hemoptysis. Hemoptysis means whether if the patient is having sputum production and the patient is having bouts of bleeding with his cough, some drops of blood are coming out. It is not like that it is coming out from the anterior, from the top portion. It should be coming out from below the bronchial level. That is called hemoptysis. Then any abnormal breath sounds. So firstly, you have to learn about the normal breath sounds. Then only you can understand if the patient is having any abnormal breath sounds. That things you have to assess. Or sometimes the patient himself or herself may admit that when I am breathing, I am hearing a different kind of sound. The sound is more or the sound is less. Or the patient attender may complain sometimes that whoever the patient or the wife or the husband may complain that whenever I am sleeping with him or her, then the patient is breathing heavily, or there is some distorted kind of sound. So that is known as abnormal breath sounds. So there are many types of abnormal breath sounds. We will come to that later. Then firstly, what is cough? What is actually cough? So cough is a reflex act. We can also cough voluntarily, but normally cough is a reflex act. which is a forceful expiration against a closed glottis, generating positive interthoracic pressure as high as 300 mmHg. Aim is to clear the airways. It is a reflex of our own body. If something is stuck in our throat, so that to clear this up, our body produces cough. So this is a kind of reflex act. So when the patient is complaining of cough, that I am having cough, then we will ask about the duration of cough. So I have already told you in the previous classes that whenever any patient is complaining of any symptom, or whenever a patient is complaining about anything, we have to inquire about the time duration. Means since, first listen. So the patient is complaining of cough. So in cough, anything about the patient complains, we will inquire further about that. So in this case, because we are studying respiratory system, so cough is an important thing for us. So we will be asking whether it is an acute cough. Means if your cough is within 3 weeks, it is shorter than 3 weeks or not. If it is shorter than 3 weeks or 21 days duration, if the patient, suppose the patient is having cough for 15 days, then below are the causes which may be causing this cough. These are the mentioned causes. Like there might be some upper respiratory tract infections, then there may be pneumonia, there may be pulmonary embolism, there might be congestive heart failure or congestive cardiac failure. So these are the reasons, causes of acute cough. Then there comes subacute cough. Like if the duration is ranging from 3 weeks to 8 weeks, the patient is complaining of cough like for 1.5 months. So it is less than 8 weeks, So if the patient is complaining of like 1.5 months of cough, it is subacute. So these coughs can be caused due to viral infections. Then this may be post-infective. Like infection has gone away, but the patient is still having cough. So this might be post-infective. Then post-nasal drip. What is post-nasal drip? It is actually when the mucus flows to our throat. Like someone is sleeping and subconsciously our mucus, then post-nasal drip. Suppose the patient is sleeping, but there is passage of mucus through the throat. Sometimes happen, someone might be swallowing the mucus. It is going backwards. So that may be a cause of subacute cough, because due to the mucus, our throat gets clogged. So to clear that mucus, our body produces cough. So that is a reason, postnasal drip. Then GERD. GERD means gastroesophageal reflux disease. Means after eating, some people have this disease, so the food content might come out from the stomach, so that will cause GERD. So that is also a cause of subacute cough, because this is merely a chronic condition. This is not new, so it will be subacute. Then chronic cough. The chronic cough would be pulmonary tuberculosis. So usually if any person is having cough for a longer duration, we suggest to do a tuberculosis test. So that is the reason, because pulmonary tuberculosis can present as chronic cough. Then bronchial asthma. Someone who is having bronchial asthma will have chronic cough. These episodes will come and go. Then COPD. Chronic obstructive pulmonary disorder. This is also a chronic cause. This also causes chronic cough. Then bronchogenic carcinoma. Then eosinophilic bronchitis. Then again postnasal drip may also cause chronic cough. Then again GERD. Drugs like ACE inhibitors. ACE inhibitors are some drugs which are used to reduce our BP, which are actually used to reduce the blood pressure. So these have a side effect, they can produce cough. And again congestive cardiac failure, again it can cause chronic cough. Then nocturnal cough. Then in these patients, there is no cough during the day. During the day, the patient is all right. But during night, the patient is complaining of cough. So you have to ask these things also, that whether you are coughing in specific time of the day, whether you are coughing when you are outside your home or you are inside your home, or whether you are coughing in day or night, or whether you are coughing after eating or not. You have to inquire all of these things so that you can come to a diagnosis. So this is nocturnal cough. Nocturnal cough means the causes will be postnasal drip. I have already explained you that when the mucus runs down the back of the nose to the throat, to the throat the mucus will run down. This is called nocturnal cough. Then again GERD, chronic bronchitis will cause this, bronchial asthma can cause this, obstructive sleep apnea. So in these patients, Whenever the patient is sleeping only, then he will suddenly wake up due to breathing difficulty and due to cough. This is called obstructive sleep apnea. Then left ventricular failure may cause nocturnal cough. And aspirations. Aspiration means whenever we are swallowing something, it should go to our food pipe, it should go to our stomach. But sometimes what happens, this food particle or any liquid particle or whatever it is, it will go to our lungs. So that is called aspiration. At night when we are sleeping, subconsciously or involuntarily, some food particles may go into our lungs. In older people, majorly these things happens. So that is aspiration. This is also called nocturnal cough. Then we will see about the sputum. Sputum, we will see the consistency, like whether it is thick or it is viscous. That sometimes you yourself may find out that your sputum, the cough you are coughing out, is very thin. It is like water only, or sometimes it may be very thick. So we have to see the thickness of the sputum. Then the amount of the sputum, how much sputum we are producing. Sometimes we may produce only this much of sputum, sometimes we may produce this much of sputum. So there is the difference in the amount. Then color of the sputum, sometimes it may be clear, crystal clear, it may be whitish, or sometimes it may be yellowish, reddish, whatever. By seeing the sputum also we can know if the patient is having hemoptysis or not. So the sputum color is important. Then postural variation is there. Like some patients are having, like in some posture, suppose they are standing, they will not have any cough. They are lying down, they will start to have coughs. So that is called postural variation. Then we will ask about smell. When the person is getting smell properly, he is able to smell things properly, we will ask about these things. Then consistency. Consistency means what type of sputum it is. Like it may be serous, that is clear and colorless. We are coughing out the sputum, but it is like water only. It is there is no color. It is not having any particles in it. It is very clear. So it may be caused due to upper respiratory tract infection, bronchoalveolar carcinoma. Then it may be mucoid. Mucoid means slimy. Slimy, you know what it means? Like some sticky substance. It is called slimy. So that may be slimy. It may be caused due to chronic bronchitis and bronchial asthma. Then there may be mucopurulent discharge. It is mixture of mucus and pus. It is also slimy, but it is also containing pus. Pus, you know? Anyone can tell what is pus? Huh? Dead cells. Yeah, pus will be there because pus cells will be there and mucus will also be there. So these are most common in bacterial infection. Then the color of the sputum. So I have already told you that the sputum might have different colors and different colors indicate different conditions. Like the sputum may be yellow or green. So in these cases, it will be most likely due to a bacterial infection. Then the sputum may be black. In coal worker, pneumoconiosis. Because in coal workers, they ingest a lot of coal while breathing. So this will produce a black color sputum. Then pink for the sputum. This may be caused due to pulmonary edema. Then rusty sputum. Rusty means there will be, you have seen rust in iron, na? So that is called rusty sputum. The color will be like this. It will be caused due to pneumococcal pneumonia. Then red currant jelly sputum. It is caused due to Klebsiella. Blood tinged sputum. This may be caused due to tuberculosis. Then the sputum may or may not have foul smell. Sometimes the sputum might be having foul smell, sometimes the sputum might not be having any smell. So if the sputum is having foul smell, these are some of the causes, like lung abscess. There is infection, there is formation of abscess in the lungs. So that is causing the foul smell. There may be bronchiectasis. There may be anaerobic bacterial infection. Now cough is over, the sputum is over, sputum part is over. Then we will proceed to different other questions, like dyspnea. What is dyspnea? Dyspnea means subjective experience of breathing discomfort that consists of quantitatively distinct sensations that may vary in intensity. The experience derives from interactions among multiple physiological, psychological, social and environmental factors that may induce secondary physiological and behavioral responses. What do you mean by dyspnea in simple terms? Can anyone tell me? Yeah, discomfort in breathing. So discomfort in breathing. So this is of varying intensity. So two person suffering from the same disease may have different types of levels of breathing difficulty. Someone whose overall level of physicality is very poor, so that person may feel more dyspneic, or the person who is little bit well built, that person may feel less type of dyspnea. So this is overall dyspnea, means difficulty in during breathing. So we will ask if the patient is having any difficulty of breathing. So first we will ask about onset. For every disease or every symptom, these questions will be more or less same. We will first ask about the onset, means since when it started. Then the duration. Then duration, since how many days you are having dyspnea. Since someone will tell that since last 6-7 days I am having dyspnea. Someone may tell that since last 1 or 2 years I am having dyspnea. So in both these cases the diagnosis will be more or less different, because someone may have feel dyspneic since last 6 to 7 days due to an acute cause. This is most likely be any bacterial or any type of viral infection. These things may cause any acute dyspnea. But if someone is telling that I am having dyspnea since 1 or 2 years, then obviously we will less likely suspect any bacterial or viral cause. We will think of any cardiac cause or any other respiratory cause or any other things, chronic things. Then about aggravating and relieving factors. Aggravating means if we do certain things, the disease will get increased, the disease process will get increased. Like in dyspnea, if someone is walking mountains, then obviously the dyspnea will increase. So this is known as aggravating factor. Relieving factor means if someone is taking rest and the dyspnea, the breathing difficulty is reducing. So this is known as relieving factor. So this is the aggravating and relieving factor, the conditions which increase or decrease the severity of the disease. Then postural variation, I've already mentioned that someone who is standing up may feel more dyspneic. When he is sitting down or she is sitting down, the person may get relieved. So that is postural variation. Then diurnal variation. Diurnal means day and night. Someone may feel more dyspneic at night, or someone may feel more dyspneic during day. So that is known as the diurnal variation. These things are very important for differential diagnosis, for differentiating the different diseases. Then the onset. Onset means within minutes. The patient has come. The patient was earlier. The patient was all right before like half an hour ago. So within minutes, the patient is complaining of severe dyspnea. Suddenly the patient is complaining of, there is no fever, nothing. Suddenly the patient is complaining that I am having breathing difficulty. So these are the most likely things that may cause this. Like pneumothorax, the collection of air in the pleural cavity. This is known as pneumothorax. Then pulmonary embolism, like anything may get stuck in the blood vessels of the airway or in the airways itself. So that is known as pulmonary embolism. Then any inhalation of foreign body. Like I told you, aspiration may be there. The person may have swallowed something, means something might have gone into his lungs. So that may be causing sudden breathing difficulty. Then laryngeal edema, left ventricular failure. These are the things that may suddenly cause any difficulty of breathing. Then hours to days, like these symptoms may start within hours, like the patient has presented to you, like since 1 hour I am having breathing difficulty, or the patient may come and tell to you that I am having this breathing difficulty since last 2 days or 1 day, like that. So these are the probable causes, like acute respiratory distress syndrome, bronchiasma, pneumonia, and left heart failure, like left ventricular failure. Then weeks to months. So these things from weeks to months, these causes will take time to develop, like COPD, chronic obstructive pulmonary disorder, then interstitial lung disease, pleural effusion, anemia. Anemia you have learned in your class. We have already taught you that in anemia, due to deficiency of oxygen, there might be some breathing difficulty. So anemia is also caused. Then thyrotoxicosis, again left ventricular failure. This may present in all these things. Left ventricular failure may be acute or chronic also. Then there is grading of dyspnea according to MMRC scale. Like some person is coming to you, you have to grade different type of dyspnea. Whether the person is having a small level of dyspnea only, like someone with the generalized weakness. Some old people, like his age maybe 70, 80, 90, 100, that person will normally feel dyspneic. Whenever he is walking, he will feel dyspneic. So that is normal for him. So you have to grade this to find out that if the person is actually having any abnormality or not. So first one is description of breathlessness, grade 0. So in that case, the patient will tell that I only get breathless with strenuous exercise. So this one is normal. So if someone is doing strenuous exercise, if you are also doing strenuous exercise, you are running or you are doing weightlifting, then obviously you will feel dyspneic, you will feel breathing difficulty. So that is more or less normal. Then stage 1, I get short of breath when hurrying on level ground or walking up a slight hill. Like the person is walking up a slight hill or in normal ground, he is hurrying up. So that is a disease condition. So the disease is progressing. This is little bit, but the disease is progressing. Then grade 2, on level ground, I walk slower than people of the same age because of breathlessness, or I have to stop for breath when walking at my own pace. Like for the same age group, like someone is of 20 or 25 years of age, the 5 people are walking. One person is always feels like he is having more breathing difficulty in comparison to others. He is finding it difficult to keep in pace with others. So that is grade 2. You have to ask the patient like that, like do you feel that others of your same age group, they are walking more easily than you? Like this, you have to inquire this. The patient will tell this. This is grade 2. Then what is grade 3? The grade 3, the patient will tell, I stop for breath after walking about 100 yards or after a few minutes on level ground. Like 100 yards is not that much. The person, if you are going to your hostel for lunch, or suppose if you are going only to the OPD and you are feeling severely dyspneic, you are not able to breathe. So obviously that is not a normal condition, that is an abnormal condition. Then grade 4, I am too breathless to leave the house, or I am breathless when dressing. The patient when dressing or while going to bathroom or while he is having just leaving the house, he will feeling this dyspnea. So that is grade 4. So this is the scale how you will know the severity of the disease, whether the person is too much dyspneic or he is normal. Then aggravating factors. So we will ask about the aggravating factors because different type of diseases will have different aggravating factors. Like exposure to allergen. If a person is having breathing difficulty on exposure to allergen, obviously we will not think about any heart disease. We will think about bronchial asthma or something else, like any allergic issue or something like exposure to allergen. He is having. We will not think about kidney disease, heart disease. First, we will think of any allergic condition. Then exercise, whether the disease is increased by exercise. If the breathing difficulty is increased by exercise, this may be due to any heart disease, any like that. Then drugs. So we have to learn about the drugs. What type of drugs the patient is taking. Some medications may cause this increase in the breathing difficulty. So you have to inquire of the drugs. Cold weather. Some people are especially having breathing difficulty during cold. But during summers, they are all right. So that things have to be accounted for. Then relieving factors. Relieving factor means the things which allow the patient to relieve. Means the disease is gone when these things are present to the patient. Like medication, the patient takes medicine and it is relieved. Then you have to think of any. Then you will come to a diagnosis that okay, this particular medicine is relieving this condition. Then this patient might have this condition, like this. Then rest. We will ask the patient if the patient is relieved on taking rest, if the breathing difficulty is gone on taking rest. Then removal of allergen, like if you put mask to a person like who is having breathing difficulty due to allergen, due to like bronchial asthma or something like that, you are taking away the allergen, the patient is completely fine. Then you will not think about any heart disease, you will firstly think about any allergic condition. Then hemoptysis, I have already told you, you just see the definition once. Hemoptysis is a medical term to describe the expectoration of blood from the lower respiratory tract, which is anywhere from the glottis, that is pharynx, with vocal cords to the alveoli. In the lower part of the respiratory tract, if someone is coughing out blood, that is called hemoptysis. Not like there is bleeding from the nose and we will call it hemoptysis, not like that. Then what are the causes of hemoptysis? One I have told you, tuberculosis, then lung abscess, bronchiectasis, pneumonia, fungal infection like aspergillosis, blastomycosis, mycosis. Then we will also ask about chest pain. Sometimes some patient will come to you like that, that whenever I am breathing, I am taking the breath, I am feeling pain in the chest. So we have to inquire about that also. That pain may also be due to any cardiac cause, or that pain may be due to any respiratory cause also. So you have to differentiate between the two. First, you will ask about the site of the pain. The patient, if the patient localizes that I am having pain in this direction or here or there, then you can localize. Then you can search for any abnormality, any malignancy or anything else, any like something like any localized, any swelling or something like that. Or if there is no site, no specific site, all over the chest, feeling the pain, then you can think of any cardiac condition also. Then onset, since when you are having the pain. Then duration, again, since which time you are having this pain. Then severity of the pain, character of the pain. Character I've already told you, na, during this abdominal pains. During abdominal pains, I've told you the character, whatever pain it is, like stabbing pain or dull pain, aching pain, like that. So these things you have to ask. Then radiation, you have to ask if the pain is radiating to any other part, like it is staying in the chest only or it is radiating to the back or anything else. So that might be any other condition. Then again about the aggravating and relieving factors, and again during diurnal means day and night, if the pain is same during day and during night, and during and seasonal variation. If you are having this pain on during cold weather or you are having this pain during summer, you have to ask this. Then retrosternal pain. What it means? It means pain behind the sternum. Can you look at the sternum? I will look at the sternum. Okay, behind the sternum. Then what are the causes? So this part is divided into three parts. Sorry. Then upper sternum, if upper retrosternal pain is there, that may be due to tracheitis, means inflammation of the trachea. Then mid and lower, that may be due to mediastinitis or mediastinal tumor or GERD also, like esophageal reflux disease. I have told you that after taking food, the food comes out. So that is, that food also brings stomach acid, HCl with it. So that will cause a heartburn. So that may be due to GERD. Then there may be diffuse esophageal spasm. There is diffuse pain. There is no localization of the pain, diffuse pain. So these are the different types of pains, retrosternal pains. Then pleural inflammation. The pleura, you know, the covering of the lungs. So that thing may be inflamed. So what are the signs of pleural inflammation? There is a catchy pain which increases on deep inspiration and on pressure. And on pressure is stabbing in character. The pain is stabbing in character, like someone is stabbing you with a knife. The pain increases on inspiration, like if someone is having a pleural inflammation, if he takes a deep breath, so due to the pleural rub, the pleural will rub against each other. So that will produce deep catchy pain. Like catchy pain means suddenly you have to stop, you cannot breathe any further. So that is called catchy pain. There is so much pain is there. So there is that may be caused due to Pankos tumor. It will cause shoulder and arm pain due to compression of C8 and T1 and 2 roots. It is a sharp shooting pain. Then erosion of ribs. There might be erosion of the ribs. So that might cause a constant dull aching pain. And one thing is there, you have to always keep angina in mind. So basically in every patient like this, we will always prefer to do an ECG so that we are not missing any cardiac angle. Sometimes any cardiac pain also may present in this type. So we have to keep angina in mind. Then after this, we will go to the general examination. For every patient, we will do this general examination. We will ask about the general condition. We will see the general condition of the patient, whether the patient is thin-built or whether the patient is well-built or fatty or not. So we have to see all these things, whether he is malnourished or he is normal build. Then you have to see the vitals, the temperature, pulse, respiratory rate, breathing rate, then blood pressure. If the patient is having cough and the patient is having high temperature and pulse and respiratory rate is also high, so in these cases we will most likely suggest an bacterial or viral infection. These things will overlap in these conditions. There will be raise of temperature, pulse, respiratory rate. Then you all know all these things, na? Pylorictus, sinuses, clubbing, lymphadenopathy, pedal edema is there, built, nourishment. We will look for all this also. Then pulse. What we will call bradycardia. What do you mean by bradycardia? Bradycardia? What is meant by bradycardia? You didn't have class about this bradycardia and tachycardia, don't know? Decrease of heartbeat is called bradycardia. So it will be caused due to hypoxia. Hypoxia can cause bradycardia. Then tachycardia means the reverse. Tachycardia means increase in the heart rate. That may be caused by pneumonia, by pulmonary embolism, ARDS, or respiratory infections may also cause this. Then respiratory rate and breathing pattern. Tachypnea. What is the normal breathing rate? Someone is telling 70 to 80, someone is telling 12 to 16, 19. 12 to 16, around 12 to 16 you can take normal breathing rate. So if it is more than 20 breaths per minute, we will call it tachypnea. So if there are more than 20 breaths per minute, that will be called tachypnea. The causes will be pneumonia, then acute pulmonary edema, pulmonary embolism, acute respiratory distress syndrome. This is a case when the person is severely dyspneic and is gasping for breath. So that is known as acute respiratory distress syndrome. That can be caused due to metabolic acidosis, means the blood has become acidic. So due to wash out the carbon dioxide, the body is producing respiration. The body is doing more respiration, more breathing. So that is a cause of tachypnea. Other causes will be fever. In fever, there may be tachypnea. The breathing rate may increase. In hypoxia, due to lack of oxygen, we will take more breaths to gain more oxygen. So that will cause tachypnea. Then excitation. When we are excited for something, we may take more deep breaths, more number of breaths. Then nervousness also, this will cause tachypnea. Then you all know these things, na? You have to look for pallor. Pallor, you know all these things. The pallor will be in, you can see pallors in chronic infections like tuberculosis, then interstitial lung disease, connective tissue disease, malignancies. Then icterus will be in core pulmonary. In core pulmonary, there will be increase in the right ventricle, size of the right ventricle. You study about this by yourself. I'm just telling you the headings. Then it may be iatrogenic, means there will be no cause. Then anti-tubercular medications may cause this. Metastasis, any metastasis to the liver of any cancer or any carcinoma. If the cells go to the liver, that may cause icterus. Icterus, what do you mean by icterus? First you tell me. Icterus? Yeah, irregular discoloration of the skin and sclera. Then it may be caused due to sepsis, secondary to any chest infection, cyanosis, due to respiratory disorders, severe asthma, tension pneumothorax, pulmonary atrioventricular malformations, then acute laryngeal edema, ARDS. Then lymphadenopathy, you have to look for it. The sites, number of lymph nodes which are enlarged. Then whether they are tender or non-tender. Tender means whether they are painful. If you are touching the limb gland, we are pressing the limb gland. If it is painful or not. Painful means tender, non-tender means non-painful. Discrete means you can differentiate them. Sometimes they can aggregate together, like 5 or 6 lymph nodes can join together. So that is known as matted. Then you will see the consistency, means what is it, if they are soft or if they are very hard like that. Then fixed, whether they are fixed or whether they can be mobile. Whether they are mobile means whether they are movable. Then you can see the overlying skin. These are the causes for lymphadenopathy. Upper respiratory tract infections, tuberculosis, HIV, lung carcinoma and lymphoma. So lastly we will see clubbing. So these are the general examination which you will see in every case. Lastly we will see clubbing, bronchogenic carcinoma, then bronchiectasis, means permanent widening of bronchial airways, lung abscess, empyema, accumulation of pus in the pleural space, then cystic fibrosis, then congenital, it may be congenital also, clubbing may be congenital also. Then unilateral clubbing may be there in Pankos tumor, tumor of the lung apex. Okay, the remaining part of examination will be taken.